Welcome to the CoROM Conversations. We're going to discuss over-the-counter meds for your Austere primary care clinic. My name is Everett Kelly. I am a paramedic. And Dr. Vashis, you can introduce yourself.
Hello, I'm Bill Vashis. I'm a PA, and I just recently finished my PhD in education. Still sounds weird to hear it.
Rolls off the tongue.
Sure.
So we need to be good at over-the-counter meds because in an austere environment, not only are they easily replaceable with any pharmacy, they last longer. A lot of these are tablets and they take up less weight. So as austere medics, we need to be very good at our primary care or over-the-counter stuff and being able to do a lot with it. So it has multiple clinical cases, generally has a safety profile that's lovely. The long shelf life with the U.S. military, the 10-year shelf life extension program for most tablets, not antibiotics, most tablets. They're very small, very low weight, and they store really, really well. And there's tons and tons of evidence. So we're going to jump right into this. And go ahead and pop in if you have any questions, but we're going to go through systems. So let's talk about one that is very common. So traveler's diarrhea, we've all had it, and it could be from just loose stools to full-fledged 3 to 5 explosive diarrheas per day, which at the moment we're having a really big outbreak on was it Cryptosporidium? There was, and then there was hantavirus earlier this year, and it's very seldom when I'm on anti-malarials that I don't have a little bit of change in my diarrhea. So you need to bring some over-the-counter stuff to deal with that. So first, let's look at assessments. We need to keep ourselves hydrated, and we can do that with a urine dipstick, looking at specific gravity, or we can grab the back of the hand and see if it tense. You can look at the mucus, the areas around the mouth, and we also assess if they have a fever, and we look for a sampler, what they eat lately. ORS is solving the majority of dehydration problems or traveler's diarrhea problems. You're losing electrolytes. We need to replace electrolytes. So having ORS in your med kit is good. And you don't have to buy the World Health Organization sachets. You can make it. And in our field guide is the World Health Organization, how to make ORS. You should have that. And ORS, it does say oral, doesn't mean that you can't rehydrate somebody rectally. And you can put it on OG, NG as well. And now let's talk about loperamide. So are we going to give loperamide to everybody? How many would be happy giving loperamide on the first sign of diarrhea? Lassa says no. Michael Potts says no. Good. So we need a reason to give drugs. And I am an avid fan that loperamide is a social drug, meaning that, and the Wilderness Medical Society has tons of good published research showing that loperamide doesn't extend and it doesn't reduce your pathology. So you can take loperamide or not take loperamide. It's going to have the same outcome from your illness. What it does is reduces stool. So if I'm getting on a plane or if I'm going to a meeting in middle of sub-Saharan Africa, I'll take it because I don't want to be rude. But loperamide is only there if you don't want to be in a difficult social situation. Bill, what is your preference for dealing with diarrhea in an operation?
Well, so one thing you didn't put on here, it's not on the slide, but it's very important in the beginning is have them define what diarrhea means to them. How many? If they're a normal once a day after coffee kind of person and they have 2, are they calling that diarrhea because it's an inconvenient stool? So I would have them quantify it first. That's a big thing because diarrhea means different things to different people. So you need to make sure that you guys are on the same level of understanding of what it is. Is it really a problem or is it a perceived problem? And so you got to take that into consideration. And then you look at your operational status. Are you in a facility where it's just inconvenient to go to the restroom, but it's right there. So, okay, so you're going to have to make a bunch of trips and just let it ride itself out depending on what's going on. And then you look for your red flags. So I'm more of a quantifying and identifying exactly what the problem is before I consider treatment. And I look at all of the options and situation to say, all right, is this a convenient thing that they are going to get on a plane or they are going to be in a meeting all day? And, then we do need to have an issue and we need to take care of that. Or is it just, hey man, just drink water and stay close to the toilet and you don't go on any drives today. You're going to stay in you get radio watch kind of thing. And you can pop in and go to the restroom anytime you need to. So I'm very much let's figure out exactly what we're dealing with before I start throwing meds at it.
And we can trend that as well, can't we? We can use the Bristol stool chart. We can trend how poorly they're being or how many times they are having a diarrhea. And your point, what's normal for them? Some people might have 3 bowel movements a day, and that's normal for them. So getting a good history from your casualty and using the Bristol stool chart. So if they have bloody stool, then even if you do want to give loperamide for social reasons, that don't. So at that point, at that point, they have dysentery. They have gone so poorly and
They could also have hemorrhoids, man. Like where's the
good
blood
point.
coming from?
All right.
Um,
Good point. Yep.
so everything is, it's really reliant on your history, making sure that that blood is not there for some other reason that's not infectious.
Yeah. If they're doing 3 to 5 bowel movements a day, maybe they do have hemorrhoids.
Well, they had them before, and now they're raw, and so now
Uh,
it's a separate deal, and they've been wiping a lot more than usual, and that's triggered the blood. So a really good history in physical cannot be underestimated.
Good. I am an avid fan of using the the urinalysis dipstick for finding blood in stool. And somebody saw my discussions and they used it in somewhere in South America. It was a vet, and he saw my articles on LinkedIn and he tested it out and he sent me the study, and it works. He used it on animals to determine bloody diarrhea. Lastly, you said loperamide reduces motility. Good.
Oh, gut motility, yeah.
Yeah, but it doesn't extend or reduce the ailment. Good.
I haven't read that study to say that, but I would say that even if you reduce it by 1 and that's a timely one, then it's definitely a consideration for use. Everything is perspective.
Yeah, valid. So when we're building our over-the-counter kit, we're going to want loperamide, we're going to want oral rehydration solution, we're going to want our urinalysis dipstick, and maybe bismuth. Anything else you can think of to deal with this?
Over-the-counter Tums.
There you go. Yep. Our Rennies here in Europe. All right, let's talk about URI. So everyone has a cough once in a while and can show with sore throats and low-grade fever and just feeling rough. So we need drugs. We need toys to give to our driver or ourselves or somebody on the job to make their life a little better. So first, we want to exclude a red flag features such as pneumonia, severe illness. So we can do an RDT if we need to. We can do ultrasound to see what their lungs look like, make sure they're hydrated, get a good sampler history on duration, trajectory, and trending of the systems. And paracetamol, ibuprofen, we call that the pain pack at the college. 1 gram of paracetamol or Tylenol for you North Americans, and 400 milligrams of ibuprofen or 75 of diclofenac if you want, and that will reduce fever and pains. I'm an avid fan as an old broken SF guy. Very rarely a week goes by where I'm not doing some sort of pain pack just because I'm old and broken. You can use nasal spray just if you're going to be driving. You don't want to keep having to blow your nose, and lots and lots of fluids. They have a sore throat. So I didn't put on here. I mean, I could have made this 15 slides, but they have a sore throat. So have Halls. I'm an avid fan of Halls or other things to be able to reduce that sore throat from coughing. And they don't get antibiotics. As much as they whinge, they don't get antibiotics. Any other points, Doc?
I would definitely. I'm a huge fan of hot salt water gargles, hot saline gargles, and it's not just one time. It's not a magic panacea. I would even describe it as like 5 times a day. If it's really bad, then you gargle with hot salt water when you first get up. You do it sometime between breakfast and lunch. You do it right after lunch. You do it sometime in the afternoon, right at or before dinner, at bedtime. All of that does the hypertonic warm saline does wonders for preventing bacterial infection in the back. It warms everything. It breaks down the congestion, the postnasal drip, and the cobblestoning from the posterior pharynx. It's a great solution, and it gets them actively involved in what's going on. And then that activity causes them to kind of feel a little bit better. I'm also a big fan of saline spray. Like, I keep it around. If you're somebody that's in a really hyper dry environment, keeping the saline mucosa nice and moist is going to prevent a lot of that irritation. Kind of rinses off the nasal pharynx so it doesn't stimulate the mucus secretion, which leads to the postnasal drip, which leads to the cough. All that stuff. It's like sandpaper, just rubbing it on your skin or your chest internally. Yeah.
Nice.
I'm not afraid of using meds, but I use them sparingly because there's side effects with every one of these medicines that you take. The guaifenesin, you have to take significant amount for it to actually be an expectorant cough suppressant. Rest and fluids cannot be underestimated, and then you don't have to worry about mixing with anything else. with these meds. So I'm a big fan of standard grandma med, hot saline gargles and saline sprays.
Awesome. Before we hit the red flags, what do you think about using point of care ultrasound? Would that differentiate any of these upper respiratory stuff?
You know what? Upper respiratory means above the pharynx. So if it gets into the lungs, it's respiratory, not upper respiratory. So, and the best secure, like as a military person, the best security in the world are the vocal cords. If they're functioning, you will violently cough to the point of vomiting to prevent anything from getting into your respiratory system. I mean, hands down, they're the best security system in the world if they're functioning. So you can listen, but I kind of go back to the physical exam portion that we've talked previously. If I can see you breathing, then I'm looking at your respiratory system. But if I can't tell that you're breathing, I can't count how many times you're breathing just by sitting there and having a conversation with you, then you don't have a respiratory problem. And so if I suspect there's something respiratory going on, yeah, I'll take a look in the lungs to see if there's any fluid consolidation. But in reality, if I'm in a clinic setting or an office setting, I should be able to hear it, or see some kind of effort breathing. But I won't hesitate to pull ultrasound out to take a look at the lungs themselves. But I should have a suspicion long before I pull that tool out.
Rule in, not a rule out. You have a question in mind as you do an ultrasound, and the question is this confirming what I already know?
Right. Well, and then they'll complain too. If they've been coughing for a while, they'll complain of this, midline upper chest kind of scratchiness, and they'll tell you, swear up and down, that it's in my lungs, but it's not. It's just that irritation of coughing. It's very unlikely. Let me walk back my statement. It's very unlikely that it's in their lungs if they're complaining that. But that postnasal drip will cause that repeated cough, and that's a sandpapery type irritation that feels like it's in your chest, but it's still upper respiratory.
Awesome. So red flags, hypoxia. So we haven't talked about SpO2. That needs to be whacked on and trended. But you're going to have clinical signs that you need to do that before you actually need to do that. Chest pain. Well, Bill just said that you can have chest pain from coughing anyway. So is it radiating anywhere? For those of us who are old guys, sure, you can have enough stress in the body that would cause a cardio involvement, but most of the time it's not going to. That chest pain is just going to be coughing. And then 10 days, it's still there are 10 days. You need to think about things. Yeah.
Duration is definitely a factor for figuring this out. But, with if you have an active population and they do some type of physical activity, there could be a reason why they're not taking full deep breaths, which can secondarily cause, respiratory issues. Say if they get cracked in the ribs, or if they're doing combatives, or, jumping, or falling, or whatever it is, and they get some costochondral pain that's preventing them from doing full excursion for their respirations. Those are things that can summarily cause secondary upper respiratory. You can get a head cold and a congestion or a contusion to your ribs. That combination, kind of sets you up for really thinking it's in the respiratory system, or at least increase your suspicion.
Let's talk about another common one. So musculoskeletal. So we're looking at sampler to find out what happened to them, or you saw it happen. You get a mechanism of injury, any deformities. I like CMS, circulation, motor, and sensory checks, past the injury or at the injury. If they can do the Ottawa ankle rules, can they step on their foot, or can they move the injury? And red flag any fractures. We can use ultrasound to see fractures, but to rule in, not to rule out. Over the counter. So diclofenac gel for topical. I'm an avid fan of that for my back, which I screwed it up jumping, and I still use it here. I'm not on pushing 60. I'm using it a bit more, and I'm surprised. We get 5% here in Europe. I tried to get some in the States last Soma, and it was like 1%. And it works, surprisingly. Like, you don't think that it would pass the skin barrier.
Yeah, Voltaren, same thing.
Yep. So then the pain pack. So oral ibuprofen with paracetamol is, so there's a study that was, I don't know, 10 years old now, 15 years old. And they did a comparison of 1 gram of paracetamol and 400 milligrams of ibuprofen to morphine. And they found it's equal to 2 milligrams of morphine. Now, if I have a fractured ankle and you give me 2 milligrams of morphine, it's not going to do much, but it'll take the edge off. So pain pack will take the edge off of a 7 out of 10 pain. You know what? That's better than nothing.
They've combined it in the States now. They have a combined acetaminophen ibuprofen tablet. They put it together. I think it's only 500 milligrams of acetaminophen and 400 of ibuprofen.
Yeah. The study showed the 500 is all you need to potentiate if you give with the opioids, it helps with opioids, and it helps with NSAIDs at 500. I like the extra 500 because that's also a good pain management. Just 1 gram of paracetamol.
I like to get the patient involved in the assessment of what level of pain they're in, along with the dose they take. So if I give them, combination here, the pain pack, say you've got one 500 of Tylenol and one 400 of ibuprofen, and you're telling them if you have 10 out of 10 pain, then take the full dose. But if you only have 5 out of 10 pain, then take a half a dose. And so what you're doing is you're giving them parameters. And this, if you make the safe assumption that your patient's intelligent to a certain level. I mean, it's better to make that assumption first, at least, and try to work with them. And when they get the squinty eyes, like, I don't understand what you're saying, then you can tailor from there, taper your explanation down, but, give them the benefit of the doubt and explain to them, if you're a 10 out of 10 take the full dose. But if you're only 5 out of 10, take a half a dose. And then what you're doing is you're getting them involved in the assessment of what their pain is, and you're giving them guidelines for how to treat it. Those patients are going to do better overall because, one, you're involving them in the treatment plan and you're giving them guidelines. What'll typically happen if you just see somebody on a Monday and you give them the pain medicines, well, they're going to take it and they're going to feel fine. Then on Thursday, they're going to kick some table or hit a corner coming around. They're going to come in and follow up with you on Friday, and they're going to say that their pain is still 10 out of 10. And they're going to forget the 3 days that they weren't in pain, right? Because they had no assessment during the process. They were taking medicine versus treating pain. It's like, it's been 4 hours, it's been 6 hours, it's been 8 hours, I'm taking a pill. And they're just following a plan, and they're not really doing an assessment. So they don't know how well their pain was or how bad it was. They just know that they've taken all their meds. They don't have any left in the bottle, and they bumped their elbow before they came in, and now it hurts again. And so you're really, that's a wasted week of treatment. So it takes a little longer to explain it, but in the end, it's actually beneficial because you're involving the patient in the treatment plan versus just giving them something to do. So it's technique. I mean, obviously it doesn't work for every patient, but when it works, it's amazing.
Another thing I like to do whenever I give, any drug, is I tell the patient, oh man, this stuff is awesome. I use it all the time. This pain pack is, man, there are so many stuff. This is going to be golden, man. This is brilliant. And it works better.
As long as you have credibility with them. Yeah.
Yeah. Fair enough.
You're selling it. And sometimes you need to sell it. Placebo is a powerful medicine.
Indeed. So looking at treatment, rice, and I left ice in there because I wanted to talk about the rice treatment. Ice is starting to go away. So no one's come up with a mnemonic for RCE, So it's rice, but just don't use wait, we can use ibuprofen. You can still use rice. The I is no longer ice, it's ibuprofen.
So I don't know. I think every study out there saying ice doesn't work. I don't know. I don't like the methods for how they do the study. And I don't think that they give enough explanation. I don't know. I've used it myself and it feels great, anecdotal, but it's kind of hard to reproduce competence. So yeah, I don't know. Well, it goes along with the explanation.
Even if it doesn't reduce swelling, it's good research on it reduces pain because now you're focused on the ice pain and not the
Yeah. Well, if you have ice, the instructions, if you give them an ice pack or something to put it on the skin, if it hurts because it's so cold when you put it on there, well, then you're stimulating more pain receptors. That's a problem, right? So you put a towel, you put a paper towel. Some people have a high tolerance. Some people start off with, a wet hand towel, and then you put the ice on top of that. That's a different temperature. So there's no standardization across the board. So I think that it's getting a bad rap. I don't know.
Fair enough.
Anybody in the group here, like, do they still recommend it? Do you guys recommend it? Do you use it for yourself? You use it for yourself, then why wouldn't it benefit your patients? This is a conversation, not just between me and Avery. You guys have a ton of experience.
Yeah, but still use it.
I do.
So yeah. So avoidance. The thing with the pain pack, I like it. I was an old SF guy. I use the hell out of it. But I have to remember that it attacks my liver. Right there's your paracetamol, and it attacks my kidneys. There's my NSAID. So there's a boxer going on the inside of my belly, just boxing everything. So you got to be careful that you don't overdo it. Let's talk about allergic rash. So this could be any type of contact dermatitis. Growing up in the States, the poison ivy, poison oak. As a kid, I actually went to the emergency department once because of poison oak. Not a good thing. And what I found, partly because of my childhood, partly because of using it, and partly because of looking at research, oatmeal. So if you get oatmeal, ground up oatmeal, and get it really wet and soapy, you use that white stuff coming out, put it onto your rash, let it dry, and it dries out. And it feels amazing. And I've used it as a clinician as well. And if there's any dermatologists in the class, you just go ahead and start writing me a terse email, but dermatologists don't like this. If it's a wet rash, dry it. If it's a dry rash, wet it. So urticaria is a wet rash. So we need to dry it. Hydrocortisone is brilliant. It dries it. What else can we use? Anyone have a favorite thing that they use with rash?
I've used topical Benadryl, diphenhydramine,
Nice. Yep.
hydrocortisone. That works.
Hydrocortisone. Good.
I've not
Green
used
tea
any of the
wraps.
cold tea wraps. I've not used that, but
Yeah. So as a reformed hippie, there is research, and it's called a styptic. I studied herbalism a bit before.
Yeah.
And so there is a styptic quality which draws stuff out with your black teas, green teas. Good. So Caleb, you said topical hydrocortisone. That's always good. And that works with wet and dry rashes. Clofedramine is Piriton. It's like, yeah, so it's going to be like DPH, diphenhydramine, except for some reason here in Europe, we can't find diphenhydramine very much, which every time I go to Soma, I get another bottle because 25 of DPH is good stuff. But Piriton works just as well. Topical steroids, delayed adrenaline, as long as you don't have systemic features, good. Once you have a breathing allergic reaction, it's time to college, we call it go to the races. So RACES. So remove from the problem, get epi, get corticosteroids, get epinephrine, and then salbutamol. Casper steroids are just going to mess up your skin. Yeah, that's true. Good. So I encourage any of you guys to try the oatmeal and get back to me next time you try it and say either I'm bollocks or it works.
Topical zinc too.
Yeah, good.
Yeah, I had a pediatrician give me topical antifungal, topical antisteroid, and topical antihistamine, the zinc. You mix it together, and you just, it's just they used to call it just like butt paste for diaper rash. You put it on that whole area, and it's all three, and it's one of those where the body. I mean, don't quote me on any of this, but the body kind of knows which one it needs, and it just seals it off, and it just does a really good job of cleaning it. I've never spent the time to figure out biochemically why does that work. It just does. So yeah, Boudreaux's
good.
I think if you look at Boudreaux's, it's literally just 40% zinc or something.
Okay.
It's not the combination of it, but you just mix 1 to 1 to 1 of all three of those things. The antibiotic, the antihistamine, and the zinc, and you just stir it up and just apply it with a tongue depressor.
Lassa says here in Germany, we do have diphenhydramine. It's called something else, Fentastil. Good.
Okay.
So moving on to insect bites and stings, which is kind of similar to rash, can be. Whenever we teach in Malta, there are mosquito problems. And it's definitely an issue pretty much everywhere you go. But for some reason in Malta, man, they just like to bite. So assessment, see if it's systemic yet. If it's just local, that's fine. If it's systemic, you need to start looking at, is there breathing problems? If you need to go to the races, like RACES, and start dealing with anaphylactic reaction. Signs of secondary infection, retain the stinger. Also make sure you scrape the stinger out and don't squeeze it.
Yeah.
And then it's a skin thing. So hydrocortisone, 5% cream if you can get it, or 1% if that's all you have. Calamine lotion. I've had that, and I don't have as good treatment with calamine lotion for some reason. Not that it's pink, that has nothing to do with it, but I think I've had better action with hydrocortisone. What do you think?
I've used both. I think when the calamine lotion goes on, after a while, it starts drying, and that's almost more irritating because it cracks the skin and it makes it feel like something's itching. Yeah, my parents' solution for that was just to put more on. So
awesome.
Yeah.
Oral antihistamines, cold compress, which always feels awesome. I like ice. So maybe that's a good indication what we were talking about earlier. The pain of the ice, just I focus on that instead of the problem with the bite. Don't take systemic corticosteroids. Yeah, Bill.
Well, I was going to say, going back to the ice thing, the way I give the explanation for using ice is, put it on so that it's cold, but not painful. And so whatever layer that you need between your skin and the ice is subjective to you. So sometimes it's just a paper towel. Sometimes it's a hand rag. Sometimes, whatever, a moist hand towel. And then you put it on there and you want to leave it so that at about 10 minutes, the skin gets kind of numb to the touch. So you take it, it slowly builds up to that really cold. After about 10 minutes, you can scratch the skin and it should feel kind of numb. Then take the ice off. Let the body warm it back up. Just do body stuff. Don't apply heat to it. Just let the body circulation warm it back up. When it gets back to normal temperature, put the ice back on and do that cycle. Once again, you're involving them in the process, and that is going to have better outcomes because they're paying attention to what's going on. And then when you ask them history, you can say what worked, what didn't work. Did it work for a little bit? Did it work for a long time? Did it not work at all? And you're getting more of a history so that you can alter the treatment to whatever they need versus just giving them a generic prescription kind of thing. So it's more of a conversation with your patient.
Awesome. Guess one problem with ice is if you're putting some ointment, hydrocortisone on it, now you're putting ice, it's going to rub off whatever you put on it. Good.
Yeah.
All right. Dehydration, that's an easy one. You have two options in this life. You can hydrate or you can die. So try to get them. And at the college, we have the hydration ladder, don't we? So oral. And I know on the JTS CPGs, the minimum better best is IV solution. And I don't have that many bags of saline. So I'm going to have to agree with Dr. Ella Korik, she was helping us teach Swedish stuff. And I've brought out the JTS CPGs and she says, bollocks, absolutely not right. The minimum is, minimum better and best is oral. Everything is oral rehydration if you can. And in austere environments, it's really important.
If you start with oral, well, it works. It's the most natural way, as long as they can tolerate it and maintain an airway and not cause any aspiration. But just because you advance it to other means, parenteral, injection, rectal, whatever you do, you can still continue oral if they're capable. So you don't stop oral when you go to the next one. It's oral and as long as they can tolerate it.
And not a third spacing problem if you do oral.
Correct.
Or rectal. Yeah, good. If you do dermatitis, I guess you could have a third space. That is third spacing. So dermatitis would be a problem. But
yeah, I've only done that on animals.
Yeah, for peds, it's common in Africa, sub-Saharan Africa and Asia.
Yeah, I don't have a history of doing that. I've done it with animals, but not
good. So over-the-counter oral rehydration solutions or electrolytes, and make sure that. So when I joined the Army in '91. They knew that we had to hydrate. And so what they did was they would give us a full canteen and they would watch us. They were like, we're not moving. You have to drink that full canteen. Output of your stomach is about 250 mils every 15 minutes. So you can drink all you want. In fact, you might be able to pee out more till your pee clear, but if it's not going into your system, it's, and I don't know if you remember this, Bill, was it Ranger School or Selection 94? There was 4 people that died because of hyponatremia or not a dehydration, hypernatremia. I don't remember if it was Ranger School or Selection, but
I remember something.
And there's a big follow up on that, and they then finally changed. Look, it's 250 mils every 15 minutes, and that's when we're getting our Camelbacks. 95, 96 Camelbacks came out. So sip. You need to sip 250 mils every 15 minutes to rehydrate as best as you can orally. Anything else you want to add to that?
No, I watched somebody that had a little bit of information and was applying it completely incorrectly. Just somebody I was watching traveling. He had a little bit too much drink the evening prior, and the next day he was trying to hydrate and he was just pounding full bottles of water, the 500s. He was pounding the 500 and then he would stand there and he would like put his hands on his stomach like, and then he would vomit it right back out and he would go grab another bottle and he was just pounding it. And I watched him more out of morbid curiosity just to see how many times he was going to do this. Like I applaud his dedication, but then I was like, hey, why don't you try just sipping that water for, I don't want to dehydrate. I'm watching you. I'll watch you. Just try this. And he was like, oh, wow, I didn't throw it back up. It was, but applaud his effort. The guy he was determined. It was awesome.
Yeah. Awesome. All right. Let's talk about heat illness. That goes hand in hand. So drugs for heat illness, it's going to be similar. So oral rehydration, aggressive hydration. At this point, I would discuss maybe using IVs if need be. What do you think, Bill?
I mean, anything to drop the core. So how do you drop the core temperature, which is down in your red flags? You put ice, you put, cool packs, submersion, misting, fanning, all of these things to get that core body temperature down. So IV fluids are just part of that process.
I'm a fan of aggressive misting and fanning just because we don't have a lot of, like WMS, they did a study last summer and it was ice and they measured by rectal temperature. Like that is the best way, ice bath. And I'm like, where are we going to have ice baths in sub-Saharan Africa or Middle East? But mist and fan. Yeah.
Yeah. Shade, you don't underestimate the obvious. That's you forget it sometimes. It's staring you in the face and you miss it.
The only thing about the desert is that the bottom 30 centimeters is 10 degrees Celsius hotter than everywhere else. So shade and get on the bonnet of the SUV. Any way you can get them off of that heat that's right on the ground, and then they'll have more access to wind and so get them shade. I'm glad you said that, Michael. Good.
Actually, going back to Thrower's comment in the chat about preemptive cooling of IV fluids. I think cool fluids would be fine. You don't want to go to the extremes, I think. And it's kind of like when the fresh whole blood administration too, they talk about heating the blood when to put that in there. You don't want to put cold blood in the body. It dropped the core temperature by, I think, 1 degree centigrade. Does anybody remember off the top of their head? I'm pulling the dusty memory. So it will affect the internal core temperature, but not as much as you think, because the body's going to warm it pretty quickly. So I think having cool fluids in there would be a benefit, because you're moving in the right direction, but you're doing it slowly and controlled. I don't know if that answers your question, Thrower.
Wouldn't it? I vaguely remember something about heart palpitations. If you're super hot and you put cold fluid, it goes through the heart. Doesn't that cause problems?
The body doesn't like to do anything fast. So if you're taking external temperatures, you want to get it down, but you want to be controlled in the process. So I think cooling that fluid wouldn't be a bad idea. I don't know. Like I wouldn't freeze it, put it that way. I wouldn't do it dramatically, but I would definitely, continuous. You want to make sure that the organs don't start shutting down, and so you're going to stay hydrated to keep everything going, maintain that perfusion pressure, and then check urine output. Yeah. Your lead and your lag measures for the treatment efficacy is something to be watching.
Good. Reflux happens a lot, and I often have forgotten it on my deployments. So have something available. Tums, Rennies, anything you can help to help balance that out. If you're going somewhere, like going to India, or we fought in Sri Lanka in '96. Man, the food, it took a while for us to get used to that food. Or living in on the DMZ in Korea with that kimchi stuff. So always, always, always remember this, that this is not cool, it's not sexy, but have a lot of them. A lot of them. Sometimes I can go through 3 or 4 Rennies after a really acidic meal. Any additions on that one?
Well, I had ginger pop into my brain. So I did a quick look, and it said, yes, it can help with alleviate acid reflux symptoms for many people, specifically those with reflux triggered by delayed gastric emptying. Yeah. It popped into my head, and before I said anything, I wanted to look it up.
Ginger. Awesome. Good. Red flags, GI bleeding, or melena, which is the tarry stool, massive weight loss, or anything new for those of us who are over 55, which I think is just you and me, Bill, and this list of people.
And any 2 of the attendees.
Minor wounds. So this is still counts as over-the-counter stuff, right? So we're not talking about antibiotics. We're talking about the ability to deal with a wound. So Dakin solution. How many of you carry Dakin solutions, which is I can put a little bit of Dakin solution in a straw, I'll fold it over and tape it, and fold it over and tape it, and that's already pre-measured. Mm-hmm. So that's my Dakin solution for wound management. What do you think, Bill?
A clean wound is a happy wound. You definitely have to assess any debris and definitely irrigate. Dilute is a good thing.
Yep.
Cleaning it, whether it's just warm soapy water, even,
Would you use soapy water in the wound?
Yes. I mean, I would irrigate it first, but then if I had to, I would clean it through it. Yes. Yeah. And then irrigate it again.
There's an interesting conversation we had. I was in Sweden in early June with some LTT, and one of the docs there was not just soapy water. There were chunks of soap. There was soap or super soapy water. And he's saying that's the only thing to really get in there and get rid of all this stuff. And I was surprised. I'll be honest. Soap in the wound it kills you as well as him, but he's a surgeon, I'm not. So
So how does laundry detergent and soap work? What it does is it provides that film that allows everything to be swept away. So it provides that barrier surrounding it, and it lubricates everything. And I'm probably messing this up, but it makes it easier for the debris to be washed away with the rest of the irrigation.
So we have another reason to have soap in our over-the-counter first aid kit. Not only are we going to do the Dr. Semmelweis option of washing our hands, but we can use it. So how would you carry your soap? Do you just get a bar of soap? I like when you go to those hotels and they have like a tiny bar of soap, I'll nick it because that's, compact. But how do you carry your soap?
The only problem with those is I like them without fragrance, because the fragrance isn't going to help anything. So I use Ivory soap or something that doesn't have a fragrance to it. That's my preference for all soap. So I like your comment, Casper. It's funny.
Yeah. Do you think liquid soap would be better for wounds because there's no chunks of soap material?
It's possible. I mean, once again, the lack of fragrance. If you can find something. Liquid is easy to carry. Same thing with the solid bar. It really depends on what you have. The single-use ones, yeah.
Yeah, the single-use soap device. Mm-hmm. Good. I remember a talk from Dr. Gurney, Jennifer Gurney, and it was in the CBGs as well. She said 9 liters of irrigation is not unheard of with a dirty wound. It's
way more than you think. It's way more than you think. It's not just running your hand under the water for a couple minutes, or a couple seconds. It's It's irrigation.
At the college, we have a rule of thumb of 3 liters minimum. I mean, you can go to 9, but if you don't do 3 liters, you're losing cool points. Michael Potts asked about alcohol, like alcohol in the wound. And I'll quote Dr. John Hagman, who's one of the writers of the TCCC. And he said that if you put anything in the wound that kills the bacteria, it's great. But if you put anything in the wound that kills you as well, that is now, your dead tissue is now food for the remaining bacteria you have. So alcohol will kill bacteria. Fantastic. But so instead of 500 million bacteria in the wound, you have 50,000 bacteria in the wound. Excellent. Your body can deal with that. But now when you use alcohol, or when I was growing up in the 60s and 70s, it's iodine for everything. So iodine and alcohol are killing your cells. Now there's dead cells, and the 50,000 bacteria that are left have lunch. So alcohol isn't the best option. What are your thoughts on that, Bill?
I've not used alcohol to clean a wound, so it's not popped into my top 5 things to do. Surface of the skin, yes, different story, but not inside the wound.
Casper said WMS doesn't recommend anything other than saline. I remember one WMS conference, somebody says, if you're willing to put it in your eye, you can put it into a wound, which I thought was really clever. So no, I wouldn't put alcohol in the eye. I'd put normal saline or tap water. And there's Hibiclens as well, but who carries Hibiclens in the wilderness? So
yeah, I don't disagree with that other than saline stuff. If I did any kind of soap stuff, I would definitely do as much irrigation afterwards as possible, because I'd want to get that out there. I think the soap would facilitate getting some of the larger chunks, the pieces that would otherwise get caught, but the rest of it is just going to be tons and tons and tons of irrigation.
My favorite is shaving cream, and no, it wouldn't go into the wound, but shaving cream to wash everything outside the wound, scraping away from the wound will get rid of all of your dirt, grime, blood stuff, because you got to clean around the wound as well. All right.
Heard of that. So I'm not used to
it. I saw that, and then I started testing it in Malta on my master's and bachelor students, and it works really well. And surprisingly, with shaving cream, it doesn't take much. The first few times I was doing it, we would look like white zombies with shaving cream everywhere. You just need like the size of your thumb. If you have a shaving dollop of shaving cream the size of your thumb, that cleans the entire arm. It's awesome. And then you don't need water to clean it out again. All right, we have 10 minutes left, and I left this last slide for this discussion, and I am looking forward to hearing what everyone says. We are going to build an austere medicine kit. What are we putting in it? You can share screen, or you can put it in the message. Basics first. What are we looking for in the basics?
So what analgesics? What antihistamines?
Gauze, saline, paracetamol. That's always a good one. The most urgent meds. Pantoprazole to say. Michael Potts, you called it out. Things with more than one use. And we've talked about that this whole evening. You need to have lots and lots of uses. Foldable basin. I like bin bags. I like bin bags because you can use it for if your ICU patient is defecating, or you can blow it up and put it behind the patient to raise the head 30 degrees, and you can make a basin out of it. Cling film. Lasso, we're not even going to have a conversation tonight about what you can do with cling film. Maybe that's next CoROM Conversations. We'll just have a dedication to cling film, and it'll be 4 hours on everything we can do. But yeah, definitely some cling film. I have a source here in Germany, a cling film. Is industrial cling film. Is a bit thicker, comes on 10 centimeter rolls, and it tears very easily, and it just never, when it folds off on itself, it doesn't get into a big ball, and it's like $6 a roll. So I don't use a kitchen cling film anymore. Lots and lots of good stuff. So at the college, when you guys come through either our conference or the classroom, we give little pill containers. They're blue pill containers about this big, and you unfold them, and there's 8 different compartments for tablets. And I've been using mine for 15 years. And it's not just an old guy's thing, but in there are Rennies, paracetamol, ibuprofen, when I have a Z-Pack in there as well, but Imodium. So lots and lots of tablets you can put into that container that will, it's called Folca, Folca, Folca. And I wish I had known about that in the Army, because that would have made my life a lot easier. Yeah, there you go, Daniel. This is my happy face. That's a Folca case. And you should have lots and lots of happy stuff in it. Good. What else do we need? 3-liter portable water filter. Yeah, Caleb, 2 is 1 is none. So I have 2. I have a straw, which is rubbish, but it's a survival straw. And then I have my Catadine portable water filter. Good. Naloxone, if you go to the U.S., too soon. That's rough. Naloxone, definitely over the counter now, isn't it?
Yep.
Good. No one said tape. Zinc oxide tape. And tape is what I don't scrimp on. Don't buy cheap tape. Get the expensive stuff, and you can do a whole bunch of stuff with it. Coban, awesome. You can do 101 things with Coban as well. Epi, good. So one thing I do every 2 years when I'm down in Malta is I'll get a EpiPen because they're cheap as chips and they're good for 2 years. And I used to be able to get vials of Epi there, but they won't let us do that anymore unless you're a doc. But yeah, have your Epi. Good. Vet wrap is another option for Coban. Yep, you're absolutely right. What else do you guys want in your over-the-counter austere medicine kit? Derm stuff. What kind of derm stuff are we going to do? So lidocaine, Casper said lidocaine. You can get lidocaine patches. Not sure if those are over the counter anymore, but Lido is good for suturing and injuries. Derm stuff, we definitely want to have hydrocortisone. Good. Antifungal cream, because when you're out as a remote team medic, you're going to have some sort of uglies happening. So fungal jungle, that's your jock itch or foot itch, and any of the tinea species. If you're a trot med guy, you need that. So yeah, good. Sunscreen. Yep. Sam splints. Good. Big fan of Sam splints. When I was in the Army, I had the Sam splints, so the old M9 bags, Bill. Not sure if you had one of those as well.
Well,
so I would
M5
get two
before that.
M5. You're right. So I'd have 2 Sam splints on the outside to hold because it was kind of a floppy thing unless you put some strength around the outside. Yeah. Lassa, you would bring IVs. I'm a fan of oral rehydration. There's even an unresponsive patient. You can do dermoclysis, proctolysis. But yeah, if you're going to carry IVs, if you're in an SUV, it'd be grand. Might as well pack an AAJT. So we just were donated an AAJT and we have it in the classroom and playing with them. I'm pretty impressed. And we just got the Ukrainian version. In fact, it's here with me in Germany. Got it from the Ukrainians I was teaching, and it's better. It's pretty awesome. All right, we have 2 minutes left, and we just opened this up for any questions, any discussions, anything that you guys want to talk about. And since this is a CoROM, you guys are faculty or students or members of the college, you can ask about CoROM comments or CoROM academic stuff. But this was the Building Austere Medical Kit CoROM Conversations for July.